Hello, this is Chris Frigno. Today we'll be discussing the deep back and the spinal cord. This is the second of two videos on the back itself, the first being the superficial back. Prior to that, we had a very quick primer on the basic anatomical terminology.
Let's take a quick look and review the vertebral column. Again, these are bones onto which the muscles of the deep back will attach. So we have a skull sitting on top of an atlas, which sits on top of an axis, so that's C1 and C2. Of course, we have the cervical vertebra. We have 7 of them. Remember, we have 7 vertebrae, but we have 8 spinal nerves in the cervical spine. We have 12 thoracic vertebrae. We have 5 lumbar vertebrae. All of these vertebrae have an intervertebral disc that sits in between them. We have that intervertebral disc continues here in between the lumbar vertebra, the L5 vertebra, and the sacrum. And then of course we have the coccyx at the bottom. On that left side we're looking at an anterior view, so the first thing we see is this vertebral body and of course that intervertebral disc. If we take a look at the posterior view, we would see these spinous processes in midline and then flanked by these transverse processes laterally. Here we have a couple key landmarks. If you were to run your finger down the middle of the cervical spine, you may not feel these spinous processes. You'd be touching soft tissue in the form of that ligamentum nuchae, which is in midline, onto which attaches the trapezius muscle. But as you get down into around C6, or even more importantly the C7 and the T1 area, you start to palpate the spinous processes. So we call this the vertebral prominence, C7. So that's a nice landmark. It's really the first significant spinous process that you palpate. If you were to palpate the scapular spine, you would run your finger down this way and you'd come to where it meets the medial border right here, and you'd be at the T3 junction. That's a great junction to know. If you were to run your finger down the medial border, and where it meets, the lateral border at the inferior angle, you'd be at the T7 junction. So we have the T3 where the scapular spine meets the medial border. We have T7 at the inferior angle. You have the T12, which would be where the bottom rib articulates with the vertebral column, and of course, good old reliable L4, which is at the top of the iliac crest. So there's some nice landmarks when you're assessing a patient. This is a review. However, it's important to note that we have this ventral ramus, and then we have this dorsal ramus. All of the muscles of the deep back will be innervated by the dorsal ramus, every single one of them. They may have a name, or they may not have a name. I think we probably have one nerve that's going to really have a name, and it's just going to be a spinal level, and that spinal level is going to be C1. So we'll see that up in the neck. Otherwise, we're really going to say all these muscles are innervated by the dorsal rami in the area. Now, of course, that dorsal ramus is a two-way street. You're going to have sensory information coming in. You're going to have motor information coming out to the deep back muscles, or sensory information coming in from the skin, or generally cutaneous regions. Same information, just a different look. Again, we have that dorsal ramus. It's coming out. This is the same picture we had previously, where we have innervation to the muscle of the deep back. This could be any general muscle that flanks the vertebral column or is in the vicinity. And then, of course, we have the sensory information that can go quite widespread. So if you were a boy, a 6-year-old boy, and you got stung by a bee here, or here, or here, you get the drift. That sensory information in the deep back overlying the vertebra would be carried by the dorsal ramus. Again, the motions of the spine are in the sagittal plane, or the frontal plane, or the coronal plane, we'll call that. In the transverse plane, we have flexion and extension in the sagittal plane, we have side bending in the frontal coronal plane, and we have rotation. And all the muscles in the deep back, they're going to work together to help contribute to these motions in the trunk. So let's examine how we got here to the deep back. So we're going to go from left to right. If we look on this left picture, we have the skin. We take off that skin, and here's what we see. We see a trapezius muscle, and we see a latissimus dorsi muscle, and then we're going to see some posterior musculature muscles that we'll get to in another talk. We remove this trapezius, and we remove this latissimus, and then here's what we see. It's not a great picture, and because a lot of stuff is missing in this area. However, the next layer we're going to see is rhomboid minor. So this is rhomboid minor up here. We have rhomboid major. And this is immediately deep to the trapezius. Of course, we have the levator scapula muscle here as well. And then we remove those muscles, and this is really now what we're going to see. So we would have had rhomboid minor coming up here like this on top, and then rhomboid major coming in here like this on the bottom, and then we would have had levator scapula coming up. Actually, levator's still in here, so we have levator scapula there. Now, below rhomboid minor, we have the serratus posterior superior and the serratus posterior inferior. The posterior is underneath that rhomboid minor, and this is a muscle of respiration, as is the inferior muscle of respiration. That's all you need to know there. So now let's go down here, and we're going to take those muscles off. You can imagine, actually, let's stay up top. If you take these muscles off, you obviously will start to see these long strap muscles. Okay, we see those long strap muscles underneath, and then we're going to see these long strap muscles underneath as well. And so now let's go down here, and we see those long strap muscles. Okay, so we're going to now talk about in subsequent slides these muscles and then muscles that are deep to these muscles, and realize again that we're talking about dorsal rami innervating them. So these deep back muscles again are innervated by the dorsal rami. We have a couple categories. We have the spinotransversalis muscles, and these muscles are really important for extending and rotating the head and the vertebral column. We have the erector spinae muscles, which again are there to extend and rotate. The erector spinae muscles are both the very long muscles that I showed on the previous slides, and muscles deep to those. Muscles deep to those help to fine-tune they're really small, and they help to fine-tune the small movements of the vertebral column. Let's say you just want to rotate a little bit, you're oscillating back and forth in a small degree of motion. You're going to use the short segmental muscles. Okay. So those short muscles are called, and the long muscles are called transversospinalis muscles. Okay, what does that mean? It goes from the transverse processes to the spinous processes. Again, these are postural muscles. Okay, and then we have the suboccipital muscles. So these are deep muscles in the neck. Suboccipital, which means underneath the occiput, which is the back of the head, back of the skull. And these are responsible for helping to rotate and extend and side bend our head and our neck. So if we were to remove the upper trap muscle, I'll add it in over here. If we were to remove the upper trap muscle, we'd cut it out. Here's generally what we would see. We would see an oblique muscle. So you see these fibers are running from superior lateral to inferior medial. So they run in this oblique fashion. And we're going to call these muscles the splenius muscles. Okay. We have splenius capitis and splenius cervicis, but all you need to know are the splenius muscles. And again, they run oblique. Now the trap muscles, if they're either linear, they're either running down like this, okay, or they're running obliquely like that. Okay. You notice that the splenius muscles are going to run, if they're with respect to the obliqueness of the trap, it's going to be running almost in the opposite direction. If this muscle contracts, let me change my color here. If this muscle contracts, which part is generally stable? This is stable, and this is going to be, this is the movable area. So you're going to contract that way. And so what's going to happen to the head? Well, if you have bilateral contraction, you're going to extend. So a bilateral contraction equals extend, and a unilateral contraction equals what? Well, you can imagine that this head is going to turn to the same side. So a unilateral contraction equals ipsilateral rotation. Okay. How else could it, what else could happen? You could have some ipsilateral extension, and maybe even some ipsilateral side bend. So rotation, extension, side bend with an ipsilateral depends on the extent of the contraction. Moving inferior from the splenius, here we have that splenius running obliquely, we see the longer erector spinae muscles. So here we have the vertebral column, the spine, if you will. And so right adjacent to the spine is the spinalis muscle. So we see these spinalis muscles coming this way. And just adjacent to the spinalis muscles would be the longissimus muscles. Why do you think they're called the longissimus muscles? Because these suckers are long. And then just adjacent to the longissimus muscles, we have the iliocostalis muscles. So here we have those iliocostalis muscles. Why are they called iliocostalis? Well, here's your ilium. So it's connecting in with the ilium here, and the costals are the ribs, so it's connecting in with the ribs all along its course laterally. Now, to learn these, you just need to look at the mnemonic I like spaghetti, or maybe I love spaghetti would even be better because of the LO here. So it's I love spaghetti from lateral to medial. So now we see the muscles deep to both the splenius and to the erector spinae, the long erector spinae. And so if we look up top, we see very straight muscles called semispinalis muscles. So remember, superficial to these muscles were the oblique muscles that ran in this direction, called the splenius muscles. So blue is splenius. But now deep to it, we have the semispinalis muscles. So you can see that they're oriented straight. Okay, so they're going to have a little less ability to rotate the neck, but you can imagine bilaterally they're going to be able to extend. They will be able to do some rotation. They could do some side bending as well. I'd like to add some side bending in there. Okay. And of course, they generally will be able to stabilize the neck with a kind of a tonic contraction. If we go down a little bit further, so as we go down here, we're going to see more semispinalis, and you'll notice that the semispinalis do get a little more oblique, but we're not going to see those very much because those erector spinae are going to be on top. We're going to see them in the neck when we take on one side, we'll take the splenius muscle off. But if we go down a little bit further, we see a thickening of these muscles, and so they go by a different name. These are your multifidus muscles. Now the multifidus are really important because you've heard of people who have low back spasm. Generally, if you have spasming of muscles, it's these multifidus muscles that are running obliquely that can get fired up and be a culprit in the spasms. Again, all of these muscles are innervated by the dorsal rami of spinal nerves, all unnamed at this point. Now, I clear my screen, and you'll notice we have some other muscles over here. Those are the suboccipital muscles, and we'll get to these in a second. So now let's take a good look at the suboccipital triangle, or those suboccipital muscles. Alright, so here we have a nice look at the suboccipital triangle, but let's get our bearings first. What muscle do we have here that's running basically straight up and down? We have the semispinalis. What we don't see is the removal of a couple other muscles. We don't see the trapezius superficially, that's running either straight up and down or a little oblique in that fashion. And what we also don't see is the splenius muscle running oblique in this direction. So this suboccipital triangle is below all of these muscles. And so what we want to do here is we want to look for the triangle. And where is that triangle? Well, let me change my color to light blue. We'll draw it in. Certainly I see a triangle here.
Now that we can see the triangle, I want to point out something rather important and something you might like to hear. You will not need to know the four muscles of the suboccipital triangle. You should know this. There are four muscles, so let's write that in. There's four muscles. You need to know their actions. So they're responsible with bilateral contractions. They help to extend the head. And with the unilateral contractions, there is rotation to the same side, that's ipsilateral, side bending to the same side. You can imagine if, let's say, this muscle contracted and nothing else, that the right side of the skull would rotate posteriorly. In other words, the person would start looking to their right. That's ipsilateral rotation. Or the right ear would go closer to the right shoulder. That's ipsilateral side bend. So you should know this. You should also know what's generally inside this triangle. So what is inside? Well, we can see the dorsal ramus of C1. That's also called the suboccipital nerve. This dorsal ramus is innervating these four muscles. So this is the motor nerve for, in this case, deep neck muscles close to the spine, innervated by dorsal rami, but specifically of C1. So you should know that the suboccipital triangle muscles are innervated by the dorsal ramus of C1. Also in the triangle is the vertebral artery. So we have the dorsal ramus of C1 and the vertebral artery. The vessel is climbing up, going laterally through the transverse foramen of C1, and then darting medially to go up into the cranial vault to serve the cerebellum and posterior aspects of the cerebrum, and as well as the brainstem. And here is a very important nerve, the dorsal ramus of C2, also known as the greater occipital nerve. The greater occipital nerve. And that is coming out from underneath the most inferior component of the triangle. Okay, so it's coming out from underneath this muscle. It's not coming out from within the triangle, but from underneath the triangle. That's very helpful when we get into identifying the greater occipital nerve in lab. So we're going to identify this muscle, this nerve. We're going to identify this nerve. So now let's see where that greater occipital nerve is going. Here we have all the muscles back in place. So this would be your upper trapezius, or the trap muscle. This would be your splenius muscle. And just below it, just peeking through here, we could see those longitudinal fibers of semispinalis. If you notice, we have the greater occipital nerve exiting the upper trap muscle in this region. Now bear in mind the suboccipital triangle is up in here, and the greater occipital nerve deep is coming out roughly this level, around the C2 vertebra level, and it came out and it's traveled up, looped around, traveling through semispinalis and ultimately poking through the upper trap. So over here, again, it would come out, it would come up and then poke out through the upper trapezius here to then serve the posterior skull in this region. So we can see the greater occipital nerve coming up this way, but keep in mind it continues on in this direction. Now this nerve can become compressed for various reasons. One, let's say that a person has a forward head posture where the muscles in the back are shortened. This could constrict the greater occipital nerve as it's coursing posteriorly. Also, an individual just may have tension in these muscles, let's say due to stress, that may compress the nerve, sending a pain signal up in this area. Either way, these individuals typically have headaches in the posterior region of the head. These are called tension headaches.
We're going to take a look at the vertebral joints, ligaments, and intervertebral discs. So we have a couple joints here, but here we have a joint. This is the Z joint or the facet joint, and notice we have a joint capsule spanning this joint, which means if you have a joint capsule, it's lined with synovium, so this is going to be a synovial joint. Sorry about that. And then we have a vertebral body here and a vertebral body here, and between those is going to be an intervertebral disc, and that's fibrocartilage. That's fibrocartilage, so we'll call this a fibrous joint. The vertebral column is heavily reliant on ligaments as well. We've seen the one ligament in the past. Here in the right side, we have this ligamentum nuchae. And if you recall, the trapezius muscle attaches to that ligamentum nuchae, and that's in the cervical spine. That ligamentum nuchae is basically a hypertrophy of what's called the supraspinous ligament. So posteriorly, connecting all the spinous processes is that supraspinous ligament. So on this picture on the upper left, the supraspinous ligament would be here. Anteriorly, stay in this picture here, we have the anterior longitudinal ligament, and this is quite broad, and the artist has shown this. And so posterior to the anterior longitudinal ligament would be these intervertebral discs, and of course the vertebral body. Now the implication for this, you can imagine that if one was to extend back, or just extend their trunk, the spinous processes, this spinous process, let's say, might go down towards this one, and this one might go up towards this one, and that would put tension on this anterior longitudinal ligament. So during extension, the anterior longitudinal ligament is stretched, therefore this ligament resists trunk extension. Conversely, if we were to flex, change my color here, if we were to flex forward, this spinous process would go up, let's say relative to this one, and this one, let's say, may go down relative to that one, and then the anterior longitudinal ligament would become less taut, but the posterior longitudinal ligament would become more taut. So the back ends of the intervertebral disc would go away from each other, depending on where you were bending, and thus the posterior longitudinal ligament would resist trunk flexion. Similarly, in interspinous ligament, so over in here we would have an interspinous ligament. Similarly, those interspinous ligaments would also resist trunk flexion. You could see the interspinous ligament over here a little bit as well, as does the ligamentum flava. That's a plural for flavum. The ligamentum flava would be ligaments that span between the lamina. So it's hard to see in here, but these are between the lamina of various vertebrae. So if I could draw that in, it's really hard for me to draw that in, but it would be somewhere, if I could get that transverse process out of the way, it'd be somewhere between the lamina of adjacent vertebra. And they also too would resist flexion. So as we can see here, everything resists trunk flexion except for that anterior longitudinal ligament. Here we have a couple more looks at these ligaments. Here we have a nicer picture of the ligamentum flavum between the lamina of adjacent vertebra. Here we see the interspinous ligaments, supraspinous ligaments, the anterior longitudinal ligaments, the posterior longitudinal ligaments, extending all the way down here, and of course another picture of the supraspinous and interspinous ligaments. All of the ligaments resist trunk flexion except for the anterior longitudinal ligament, which is resisting extension. So once again, in between the vertebral bodies of adjacent vertebrae are the intervertebral discs. These intervertebral discs are made of fibrocartilage. So we'll call it fibrocartilage there. And this fibrocartilage is quite remarkable, and it's quite different depending on where you are on the disc. On the outside of the disc, you have this structure called the annulus fibrosus. So this is the quintessential fibrocartilage. On the inside, it's a little more gelatinous. Not quite liquidy, but it's a more gelatinous, and this is called the nucleus pulposus. And so these are this disc is designed to withstand quite a bit of axial loading and a little bit of shearing, back and forth movement like this. Depending on where you're at in the spine, say in the lumbar spine, you have an enormous amount of axial loading plus an enormous amount of pressure on particular regions. Depending on the activity. Here you would have a lot of pressure during trunk flexion anteriorly, laterally during side bending on either side, depending on which way you were side bending. Extension, you might get more pressure posteriorly. And then of course there might be shifts in this gelatinous mass on the inside, depending on the movements that you're performing.
In these slides we'll discuss some clinical correlates. Every one of you will see someone in their career with back pain. Most of you will see loads and loads of people with back pain. Now there's lots of back pain, especially here in the US, but worldwide we spend a lot of money. We have the leading cause of pain is back pain. It's the second cause of disability in adults. 6 million people at any given time have chronic back pain. Now these stats were from 2010. Certainly the population has increased, so this number is increased as well. We have a whole host of reasons why someone might have pain. Now, this is a pretty good list. Certainly it's not all inclusive, but a lot of these we're going to talk about. We've talked about scoliosis already. We're going to talk quite a bit about a few of these. We're not going to talk about kidney stones, infections, endometriosis, and fibromyalgia, but certainly there's a whole nor pregnancy, but there's a whole host of reasons why someone might be having pain that may not be directly due to back structures themselves. So this is quite a similar list to the last slide. We can see things here in the vertebra, such as spondylolysis and spondylolisthesis, ankylosing spondylitis, and vertebral body fractures. Let's take this one first. Certainly fracture can occur. Usually it occurs either with high impact events, so let's say from a fall, or in those with osteoporosis. Ankylosing spondylitis, the itis referring to inflammation, spondyle referring to the vertebral column, and ankylosis really referring to a kind of a fusion, if you will. So it's this fusing of vertebra, or the coming together of vertebra due to an inflammatory disorder. Spondylolisthesis is quite interesting. Here we can see the L5 vertebral body. You see the L4 vertebral body directly over L5. This is relatively normal. If you notice, this is the beginning of the sacral spine. And you can see how the anterior margin of the L5 vertebral body doesn't line up right on top of the anterior body of the sacral region. So there is a slipping in this direction of the upper vertebral column, or the entire vertebral column, with respect to the remaining vertebral column at the sacral region. Now, this slipping could be due to this spondylolysis, which is a fracture within the area called the pars interarticularis of the vertebra. This is a thin bone segment that's joining the two vertebrae. So those are issues with the vertebra. Well, I'm sure we've all heard of people who are having disc issues in their spine, either in their cervical spine or their lumbar spine, usually not in the thoracic spine. There's degenerative disc disease, bulging disc, and herniated disc. I'm going to go into each one of these. But here we could see this looks like a herniation of sorts of the nucleus pulposus that's protruded out through the annulus. And we can see some other examples of that. This would also be a herniation. And then we can see maybe some small little bulges. Let's see, maybe right in here we might have an intervertebral disc that's bulged out. That little black area here going into the vertebral canal. So this is a nice summary slide of these three conditions. Here we can see a degenerative disc. So what does that mean? Well, here we have a normal disc. It's plump, it's full of fluid. As we age, things dry out, if you will, or degrade, and this is what it looks like, degraded. So this is a condition that usually happens in the 4th, more in the 5th, and beyond in the 6th, 7th, and 8th decades of life. It's real common to see this in the 5th decade of life and beyond. What are the implications of that? Well, you could imagine that with this disc here, you have a certain amount of disc height. When you lose space here, and then if you were to lose space in other regions as well, we can see it here, you actually lose height. This is why people actually get shorter, is because of the degeneration going on. So you lose, let's say, 2 millimeters here, 2 millimeters here, and so forth and so on. And those 2 millimeters throughout the entire vertebral column add up. Well, that's okay. We all get shorter. But the bigger reason is this hydrated disc sets the intervertebral foramina size. So remember, the intervertebral foramina is formed by the upper vertebra and the lower vertebra coming together. If you lose disc height, this area and this area will come closer together, so the intervertebral foramina will get smaller. And remember that you have a spinal nerve that's exiting out of this intervertebral foramina. Therefore, it might get pinched between these two bones. Bulging discs are exactly what you might think they are. It's a disc that has protruded out of its normal containment area. So it's normally contained between the two vertebrae, and the disc has protruded outwards some. Now, to me, this looks a bit like a herniation, but what they're showing here is the purple and not the blue. That's the key here. So the purple is the annulus, and so it's the annulus that's pushing outward. Versus a herniated disc is that the nucleus pulposus has herniated out through the annulus fibrosus. So this would be a herniation. Either of these could be pinching on neural substances behind here. So what structures would that be? Well, it could be the spinal cord itself running up through here. Remember that the spinal cord ends about at this level. So in the lower lumbar or sacral region, it's probably nerve roots that are coming and exiting out in this area. Now, bulges and herniations normally occur earlier in life, in the 20s, 30s, and 40s, but mostly in the 30s and 40s. This is real common in the weekend warrior. This is real common in the person who sits at a desk and has a flexed lumbar spine for most of their day, and then they come home and let's say they decide to rake leaves or pick up some heavy packages. Now, I would be remiss if I didn't mention that all of these occur in the cervical spine as well, and theoretically in the thoracic spine. So while I'm showing a lumbar region, and I've mentioned lumbar several times, again, this could easily happen in the cervical spine. Osteophytes are also really common and could be a pain generator. So just like we have in our synovial joints where we have bony spurring that goes on, we see this in the weight-bearing joints, we see it in the non-weight-bearing joints, mostly in the weight-bearing joints. We can have osteophytes. So here we can see some osteophytic changes. So we could call all these little outcroppings, if you will, osteophytes. The next two slides are on bulging and herniated discs. Now, I know I've already mentioned it, and I'm probably belaboring the point, but again, these are just extremely common, so I want to go over a few things. So this is, again, a picture of the nucleus pulposus that has herniated through the annulus, and you can see it goes and hits the spinal nerve. Now, why does it go in this direction? Well, if you recall, we have what's called a posterior longitudinal ligament right here. The anterior longitudinal ligament would be roughly here. Again, this is a cross section, so we would just be seeing a little component of it. The anterior longitudinal ligament is very wide and very, very strong. Now, the posterior longitudinal ligament is also strong, but it's quite narrow. It sits about right here to here. So when a disc gets pushed back, it's going to hit that posterior longitudinal ligament, and it's going to find the path of least resistance, which will be posterior but lateral, either posterior lateral to one side or to the other. And again, so what's here? Well, we have a spinal nerve. So it's usually the spinal nerve that gets compressed, not necessarily the spinal cord itself, but because of that posterior longitudinal ligament. In the lumbar spine, recall that we have nerves that descend down to exit. Here, if we're at L3, the spinal cord itself has ended way up here at L2, L1, L2, and it's sent down within the cauda equina, ventral and dorsal rami, that are going to exit some distance down. So this is the L3 nerve. This is the L3, L4 intervertebral disc. With a herniation, a posterior lateral herniation of the L3, L4 disc, it has a chance of hitting the L3 nerve, and it does quite often, but it has a greater chance of hitting the L4 spinal nerve as it's descending down to exit between L4 and L5. Here we see an MRI showing a lumbar disc herniation between the L3 and L4 vertebral levels. It's quite clear where you have this intervertebral disc and you have some disc fragment protruding back into the vertebral canal. I would like you guys to be able to read an MRI like this and understand at what spinal level or vertebral level you're at. The dead giveaway in the lumbar spine is right here. This is the sacrum. And so you can see a relatively consistent curvature here. And at some point you take a very sharp change in angle. It's this sharp change in angle that should give away that you're at the L5 to S1 vertebral level. The other way to recognize you're at the sacrum is the conical shape. Note that the dimensions of a typical lumbar vertebra in the anterior part and the posterior part of at least the vertebral body are similar. This height and this height are similar. But here we can see a long anterior part of the sacrum and a shorter posterior part. Similarly, you have a longer superior aspect and a shorter inferior aspect. So counting up from there, we could count up. Here's L5, L4, L3, and so on. The intervertebral discs are filled with fluid, and the darker they are, the more degraded the intervertebral disc is. So this is actually quite nice disc. This looks like a disc of a younger individual, and these here look dark and look narrow as well. So these look like discs of an older individual, or at least someone with degenerative disc disease here, and somewhat here, although this height could be because of the herniation where they've actually lost fluid out this way. Osteoporosis is a massive problem in the aging population. It is often seen in the spine. Here we can see some compression fractures as a result of osteoporosis. So again, osteoporosis is low bone density. Because of the low bone density, particularly in the trabecular bone, or the the mesh-like bone in the vertebral bodies, the mesh is so delicate that it fractures due to the weight of the body coming down. And on MRI, we can see this cupping. So this cupping is indicative of osteoporotic changes. So this isn't too bad. This might be a minor compression fracture, if there is such a thing. But we see some really prominent cupping here and horrific cupping here. This is someone who's really done some damage here on their spine. Again, this is because of the weight of the body coming down onto some poor bone stock, if you will. Here we can see good bone, where we have this nice trabecular weaving of bone, and this would be an osteoporotic bone. You can just see how there isn't any support here, and if somebody decided to sit down quite hard on a firm chair, maybe the weight of their body comes and impacts this and fractures the vertebral body. So just to summarize, back pain can come from a multitude of conditions. Could simply be from some posture abnormalities. You could get some muscle spasms. You could have facet joint issues, so this is more of an articular issue from between bone to bone, or compression of nerve tissue, likely due to either a degenerative disc, a herniated disc, or a bulging disc. Obviously, we have other generators such as compression fractures, spondylolisthesis, etc. I'd like to thank you for hanging in here to the end and for your attention. Please let me know if you have any questions. Feel free to email me or come see me in my office.